So again,
Thank you, Alexander.
so you and James Overholser have done this very
Yeah,
cool special issue on
yeah.
perfectionism. And there kind of seems to be a growing trend in interest on transdiagnostic factors over the last decade. And I would say that like perfectionism is like a transdiagnostic factor par excellence. So
Absolutely.
really interested kind of what led to the initial idea of creating this special issue with James.
Yeah, it was about founding the perfectionism almost everywhere. My interest is, of course, it's personal because it's something I know pretty well, and also it's a tricky trait because on the one hand, one can imagine that you know. Perfectionist may help because you want to do better, you want to do more, and to a certain extent, you can have the idea that it is adaptive,
Yeah.
but actually it is not, at least the way we assess it in a clinical practice. And then I published a paper on a large sample of outpatients, and with personality disorders, and we discovered that perfectionism was present in all personality disorders, everyone.
Wow.
And associated with a lot of distress. So the more you are perfectionist, the more you have symptoms and with interpersonal problems. Okay, and so well, it's not just something connected to eating disorders, obsessive compulsive disorders, or obsessive compulsive personality disorders. No, it's everywhere.
Yeah.
Okay. So I think it deserved to be investigated from many perspectives and among clients with different disorders.
So do you have your sense of why do you think, what makes perfectionism such a prevalent trait across disorders?
Well, that's a good question. I don't have an answer to because it's can it be a social tendency? But it's hard to say because on one hand, I don't see a society where doing things the right way is such an issue. Okay.
Yeah.
So it's not in music, it's not in art. On one hand, it looks like it's everything is loser, and you do things and it's okay. But actually, it's prevalent. So I don't have an idea why it is so important. And what I have I have a clearer idea that perfectionism is not a disease in itself. But it's a cure. It's a cure that doesn't work. Okay, so you may want to call it maladaptive coping, you may want to call it defensive mechanism, but is used to fix something else.
Like an attempted solution at something, right?
It's a maladaptive solution. So you have some personal issues at any level, and then you try to increase your standards, to comply with standards, to avoid mistakes, to present yourself to others as flawless, but then it doesn't work, and then you have problems.
Yeah. So in your intro paper with James, you cite.
I want to say that James did a very great job.
I agree.
Yes, it deserves to be recognized. He did really great, and he's a very nice person to work with.
Well, I mean, now I want to make explicit. I think the issue is fantastic because you've been able to string together so many different approaches, but you can kind of find a good coherence among them, which is also really nice to see across the papers.
Yeah, good.
You cite in that first intro paper with James, you cite a recent meta-analysis by Curran and Hill that basically suggests that over the last 30 years, the trait of perfectionism has been increasing. And I want to get your sense. Do you think that this is just like we're doing better, more research, or do you think that there are good reasons for an actual increase in perfectionism over the years?
Well, again, it's hard to say because my bird's eye view over society would say the opposite. That is perfectionism. I don't see it much. You can just imagine the headline intelligence of people reading things on Facebook and thinking they are experts, which is horrible. Or some reality show where, okay, you are there, you have some muscles, you are nice, you smile, and then you can be successful. So I don't see the standards. I see a mess. Okay, and so I would surprise. I would more think that it's about doing better research.
Okay, that makes sense.
But I struggle between what I observe in the clinic and what I see in the society.
Yeah, I think that's a struggle most of us feel, actually, from
Yeah,
a clinical and research perspective, right? That
yeah.
division. So, do you have a sense of our understanding of perfectionism having clinically, and not just clinically, but in general? Do you feel that it's evolved in some way over the last 20, 30 years? Meaning, as we're reading these papers, you get a sense that there are many different ways to conceptualize it, its causes, its treatment. Do we actually know more about perfectionism now than we did 3 decades ago?
I think so, and what I can tell you is that I do know more after having edited the issue than I knew before.
That's a good
And
sign.
because no, the others were really great in describing their understanding of perfectionism, and in describing how they handle with the problem based on a very solid case formulation. Then one may disagree with a different conceptualization. This is normal, okay? But they addressed it from many perspectives, and there are consistencies, okay? For example, it is made explicit in different languages and and different conceptualizations, but the idea that perfectionism is maladaptive coping, I think, is present in all the papers.
Yes.
So just summarizing, you have a CBT conceptualization, and there is clear that perfectionism is to fix the idea of being flawed, that you won't be accepted if you're not perfect. And Hewitt and colleagues, who are probably the leading authors in the research field of perfectionism, made it very clear. Again, it's a matter of presenting oneself, because if you present, just to quote Nirvana, come as you are, well, perfectionists cannot come as they are.
Right.
They need to wear a mask in a way. And the radically open DBT, again, it's clear that perfectionism is a coping. My own paper on metacognitive interpersonal therapy, we are very rigid in saying that perfectionism is the way you cope with imagine, anticipated, or just appraise the reaction of the other. Okay. And the compassion focused therapy, again, I think it's clear about that. And I don't remember if I'm missing something. Probably, that's purposeful. I wasn't mentioning your paper, so you speak for yourself and Bruce Ecker.
Well, there's also the dynamic relational, I believe, right? So you have quite a good representation. You have CBT,
yes,
dynamic relational, yeah, metacognitive interpersonal therapy, radically open DBT, compassion focused therapy,
yes,
and memory consolidation methods. Yeah. And I think, honestly, you've just done the best synthesis, because I think from a memory consolidation perspective, it's basically comes down to an attempted solution. Right?
Yeah, exactly.
What we would call a pro-symptom position. The person really feels that it's better to try being perfect than to have the awful, life of the good enough.
Exactly. Right? And as a personal opinion, I can agree and disagree with some of the positions. My personal idea is that perfectionism is mostly part of the coping schema. Okay, that is, people start from somewhere else. Okay, and they can start from the idea that they want to just do what they hope, what they want, what they like. So being driven by other motives than social rank, which is autonomy, exploration, group inclusion, attachment, by the way, or even social rank. But if you do the things the way you would spontaneously do, then you meet a reaction of the other as overly critically harsh, spiteful, Or alternatively, because I've seen that in my clinical practice, it's not just about being criticized, but making the others suffer. Okay, if I do things my own way, then my mother will suffer. She's depressed. She's taking care of her grandmother. My father is an alcoholic. So if I am autonomous, then I will fail my mother in taking care of my alcoholic father. Okay. So then being perfect is not just a matter of being accepted because you want to be valued, you want to excel. Okay. It's just because it's like I discovered that when I did things perfectly, the situation was more regulated.
Yeah.
Okay, mom felt a bit better. The situation was less mess home. Okay, so it's a coping, but not necessarily coping of a specific aspect.
I
Okay.
really enjoyed that there's the way you describe it, you can really feel the interpersonal cycle or schema playing out.
Yes, absolutely, absolutely.
Yeah.
And then once you meet the response of the other, which be neglecting,
Yeah.
so it's attachment, which be critical, so it's social rank, it's been excluding, so group inclusion and you are the outcast, or suffering, which moves you to the position of inverted caregiving, so you have to take care of the people you want to be taken care from, then you raise the bar.
Yeah.
Okay, because what you are is not enough, what you are is wrong, what you are is flawed, then you have to repair yourself. Okay, and that's the problem, because that kind of trying to fixing things, make things work, because it never ends.
So I think you just summarized really well what I think would be a conceptualization most offers from most approaches can get behind about the causes, right?
Yeah.
Maybe it's also interesting to look at the flip side, which is about the treatment aspect, right? Because it
Yeah.
seems like as you read the papers, you can see the kind of common goal of trying to improve or increase clients' flexibility, for example.
Yeah.
You want to say a bit about the commonalities and differences you felt?
Yes, no, that's very important. I see, I would say there are two commonalities. Okay. Uh, One is that treatment needs to include minding about something else than performance, which also is my personal position. So honestly, I'm not much personally in my model, and I'm personally me as a clinician. I don't care much about lowering your standard. Okay, so I don't work inside social rank. It's more about try and make your mind more focused, more concerned about life, about other things, about things that are important to you. Okay,
Right.
so it's not just about accept you are flawed, you are imperfect, whatever, but mind that you have something else. And if you focus on something else, then you will mind less about performance. Okay, and I think that's important because it's present in Hewitt and others, so the dynamic approach. It's present in the CBT approach by Alex Rosenthal. It's present in the radically open DBT. It's present in my paper. It's present in compassion.
Yeah.
Okay, and so I think it's some issue that we all want. That is, we try and coach our clients to focus their minds on something that is not about being more and more and more, so achieving always a higher performance standard they will never be up to. Okay,
Yeah.
so that's sure one key issue. I think that's probably the most important. And the other is, is less trans-therapeutic, so to say, but I could see it, is, and I like it a lot, it's kind of helping the person delivering, forming a more compassionate self-view. Okay,
Yeah.
so again, it's not just reducing your standards, but it's try to adopt a different position. Okay.
Right. Yeah, it's really interesting what you're saying. I'm gonna speak now from my biased position, also having written one of the papers. I
Yeah,
think it's great that you're highlighting that we're not really asking people to lower their standards per se. It
yeah,
doesn't feel like that's the core thing, right? It's you're kind of reframing, doing almost some values-based reassessment, right?
kind of, kind
Yeah.
of. Kind
Hmm.
of. I wouldn't name them values because, but just because it may be more connected to acceptance and commitment therapy.
Yeah, sure.
But no, but it's just a matter of words. But that said, I fully agree with you. You can call them values, you can call them wishes, you can call them core needs.
Yeah.
That's the point.
So
Okay.
our mutual friend Joanna Podina did the
Yeah.
concluding commentary. Fantastic paper,
Beautiful.
beautiful to wrap up, kind of commenting on the papers. And she caught up. I was also noticing as I was reading the issue, but she caught up with even nicer because she says directly that there were at least 3 of the case studies that explicitly used experiential methods.
Yeah.
I found that very interesting. And I know that you also are very interested in this topic. So I'd like to get your comment on that. Does this seem to you like some suggestion that there are some common interventions that might be helpful as well?
Yes, and that's great. And actually, no, I think Joanna delivered a very nice commentary because she was both clinically focused and, and research oriented. So quite brilliant. I'm also happy because she's such a rising figure in a society for the exploration of psychotherapy integration world. So that's great at any level. But well, after having read her comment, I realized that things, maybe it's even more pronounced if you include in the experiential techniques the role of behavioral exercise, which are present in the CBT paper and in the radically open DBT paper. Okay, so the core, the idea is that you want to change the internalized representations of self and others. That's the issue of when you work at the level of personality traits.
Yeah.
Okay, and perfectionism is a personality trait, is a maladaptive personality trait, and if you want to address these personality features, well, you don't just have your clients changing their mind. It's not enough.
Yeah.
I'm deeply convinced that if you want to break these patterns at the core, which is the embodied, procedural, tacit, implicit, call it whatever you like, aspect of the schema, you have to move things. Okay, you have to move their body, you have to move their mind, but after having experienced something they suffer from. So basically, if you tend to behave perfectionistically, okay, and you have to stop that pattern. So you can do it in a imagery exercise, okay, and which is what you did in a way, and which is what I did, which is compassion focused therapy did. You has to, and I want to know your opinion about that. You have to let arousal increase,
Yeah.
so you don't protect your client and leave them in the so-called window of tolerance.
Uh-huh.
Okay, you must bring them a little in the discomfort zone, because there you can offer them tools for self-regulation.
Yeah.
Okay, you did it, you and Bruce did it,
Correct.
and Marcela Mados has Stein's title in the very beautiful paper on compassion focused therapy did it.
Yeah.
Did it. So a combination of imagery exposure and mindfulness technique or body-oriented regulation techniques. And there you discover that you can express your vulnerable side,
Yeah.
but then you can do something else physically, experientially.
Yeah.
Okay. And I think, I'm strongly an advocate for that. I think therapy needs to move in that direction. It's not just about changing your opinion, changing your mind, changing your thoughts.
I
You
mean,
have
this
to
is
change the way you experience something different. And so the call for more exposure-based
yeah.
therapists, by the way, I think it's important, but I'm looking forward to what you think.
Well, what I think is we are both very boring in Giancarlo, because we agree so much. that this is one of those awful things when you go to conferences and people just agree
Yeah,
it's
yeah,
so
yeah, yeah.
boring. But I mean, for myself, so first of all, yes, I do totally agree. I think, I really like that old Gestalt saying that you can't leave a place without first going there and staying there. And another way is kind of the way out is through, in a certain sense. I mean, if
Yeah,
you're touching on core schematic
yeah,
aspects, these are affect laden. And
yeah,
if you really want to work with them, these activation of affect laden experiences, I would say
yeah,
prerequisite, right?
yeah,
Now,
yeah,
from a memory consolidation perspective, it's interesting because, from a purely experimental lab position, sometimes arousal is not necessary. But from a clinical perspective, if you're touching on memories that are clearly affect laden, you will most of the time have a need to arouse affect, right? And you as a
yeah, yeah,
therapist to
absolutely.
tolerate it, right? To tolerate,
Yes, exactly.
which
And
may be the hardest part for some practicing clinicians, right? Is staying with that aroused affect in both people in the room.
which is one point you strongly advocate for. That is, training clinician, doing what is needed.
Exactly. I think the deliberate practice of people tolerating affect rising, in a sense, not treating clients like porcelain, of course, wanting them to be regulated, but believing that, of course, they can tolerate, especially if you're moving in a direction that is facilitative of undoing some maladaptive schematic course, of course.
I think that's key. And turning back to perfectionism,
Yeah.
and if you don't ask clients to expose their vulnerable side, to try and pursue their most valued goals or wishes or needs,
Yeah.
and if you don't ask them to abandon their coping strategies related to perfectionism, which then leads to avoidance, which then leads to procrastination, if they don't try and break these coping mechanisms or try to expose themselves in front of the harshful, neglecting, dominant other, if they don't take the risk,
Yeah.
I don't see a point where they change. And here I must say that I'm a bit skeptical about, maybe I'm finding an area for disagreement. And but you tell me.
Great.
Let's try.
We'll see. We'll see.
And I'm skeptical that common factors will do the job.
Yeah.
Okay. I have had conversation very friendly, but also very, very, passionate about the role of corrective emotional experience. Okay. So you are there with expectation that even the therapists will criticize you, abandon you, neglect you if you're not perfect. Okay. And then a skilled therapist is able to recognize that pattern. And for example, okay, I've delivered you the homework. Try and abstain from studying 8 hours a day. Try to abstain from exercising in a wellness center for 4 hours so the body is perfect. Try to reduce. Okay, the client don't do. Then they are ashamed because they think the therapist will be disappointed.
Right.
Okay, so you spot the interpersonal pattern and you walk through that. So the clients discover that you accept them even if they, didn't comply with your goals, with your task.
Right.
Okay, so you pass the relational test, so to way, you offer a corrective experience, and the idea is that this is sufficient to break this pattern. I think it is not.
Yeah.
It may be in some very mild cases, nice persons who just have a very small problem, but in the majority of the situation, this is necessary. I'm not saying it is not necessary. You work through the therapy relationship, and but then you have to let the temperature rise,
Yeah.
and then ask the client, try to do something different, try to do something new. So without this kind of exposure, I don't think the core patterns will change. Or they may do, but I'm not sure it's so likely.
So I can give you my reaction to that, and I'll try not to be super boring and just agree. So
No.
no, I think I can try. So I've kind
I can threat you and say that Bruce Wample will be disappointed that you agree with me. I
yes,
don't know.
I know. I'm happy to disappoint someone in the process. That's always a good sign.
No, we disappoint Bruce together.
Let's do it. Let's do it. So disappointing maybe a lot of people at SEPI. I'm not sure. We'll see. I think I've come to see common factors a bit like, the Carl Rogers supposed necessary and sufficient conditions that he said: empathy, congruence, right?
Yeah.
I think you can see them as always somewhat necessary and insufficient, basically.
I totally agree.
And these common factors like alliance, empathic resonance, all of these things seem to be quite necessary, or at least probably very important, but generally maybe insufficient,
Yes,
especially in our area of interest. I know that we both are very interested in personality pathology and disorders. I
absolutely.
think there you can definitely see that sometimes common is not enough.
Absolutely. No, yes, I think they are necessary because if you are not able to navigate through the therapy relationship, detect spot ruptures, repair them, meta communicate, and be genuine and congruent and caring and warm, I don't think you get much.
Yeah.
But then you have to dare.
Yeah.
Okay. It's one thing. It's okay. Try to see things from a different perspective. Maybe you are less, flawed than you think. But it's quite different that you bring the client into a interpersonal moment in which they are exposed to criticism or to making the other suffer, and then you use compassionate chair work. You use, exposure, memory consolidation, you do guided imagery and scripting, as I would do, or probably as also would schema therapy do, or you use to share in the emotion focused therapy
Correct.
way. That's a completely different word. Clients make a different experiences. No, I remember a client of mine, highly perfectionistic, and she could, she realized that she had a problem. When I asked her for a two chair, she said she couldn't even speak for herself.
Yeah.
No, I don't have the right. I don't have the right. I know that my mother will makes me suffer, but I cannot disappoint her.
Yeah.
Okay, so she couldn't move further into the chair work.
Yeah.
Okay, but that was good because she realized how she was blocked.
Yes.
And how strong the pattern was. Okay, and I had a similar experience with another client of mine, more or less the same. I tried to let her speak to the other self in the other chair and say, okay, I like you as you are. You don't need to be perfect. I don't remember the details. And she said, I try, but it's so difficult. I can't.
Yeah. Perfect.
And then again, you can think that the experiment was unsuccessful. No, it was super successful because she realized, okay, so that's my inner world.
Exactly.
So it's not about pleasing others. It's not about meeting social standards, but it's about it's internalized. Okay. And I know there's one thing I want to know your opinion because maybe that's the point I can disagree with some of the papers. Okay, so sometimes it's like you try to make clients change their behaviors so to have more chances to obtain, positive responses from the other. Okay, and I disagree because it's a tricky issue because sometimes you get disappointing responses. Okay, and I think that using behavioral experiments on or all of these techniques is needed to change your internalized representations of self and others.
Yeah.
Okay, and then you can try to do something to live a richer life. Okay, yeah. But if you if you set a goal in the external reality too early, and maybe you are making your clients more dependent on the feedback of the other.
I agree with you. I mean, from Bruce Hecker's work, my co-author, he uses a term called being counteractive, which is you're trying to counter the symptom, but that in itself is a tricky issue, because if you're anxious and just trying to learn to get relaxed while you're anxious, you're basically just fighting yourself and your own internal schemas all the time.
Exactly.
Right. So it is let's say, more of a band-aid that can be very helpful, but
Yes, exactly.
not so much the core change we might want. Right.
Yeah.
Well, it's really interesting, because also as I'm hearing you, I get a sense that there's still some discussion over causes and treatment, of course, regarding this issue, right? And I'm wondering, because I'm also conscious of time, and I think we want people to go read the papers as well.
Yes, of course.
So I also wanted to kind of throw back to you just a more general question, which is there something that you'd like just to mention in terms of this experience you had writing organizing the issue, or any takeaway idea you want to leave so that people will actually go read it afterwards?
Yes, I think that what I learned from the papers is that I think the needed ingredients are, for sure, there is a focus on the therapy relationship. For example, there's a nice part in the paper by Hewitt and colleagues, the one on dynamic approach, and in which the client was in a group, and she was struggling with her patterns, and she had a very significant improvement when the therapist in the group self-disclosed that she had struggled with perfectionism herself.
Right.
Okay, so that's very important. So working through the therapy relationship is important. And if we know that we have to be in touch with our weaknesses and flaws and soft spots, that's important. And self-disclosure is a very powerful instrument. So that's key. And many papers advocate for a preliminary part on psychoeducation about perfectionism. Okay, and I would leave the readers, form their own understanding, because I can agree that psychoeducation might be useful, but it's the way you deliver it. I'm more for a shared formulation than psychoeducation. But in any case, almost all the papers try to focus on that. Then the focus on the healthy self, and that's important. And then the focus on trying to break patterns, both in their mind and in their everyday life. So there's a need for some, behavioral practice aimed at doing something different. I think these are core elements, and if you combine them, of course, in a well-designed and structured idea of how the treatment should work, I think you can treat these people. Then the last, what we discussed about, is that you can dare and let the temperature rise. So imagery exposure, 2 chairs, compassionate chair. That's beautiful. That I think that can be a game changer with some clients.
So unfortunately, again, we're in agreement.
Okay.
And having said that, maybe we should just leave it at that, because I think you just did the best possible concluding remarks summary. Okay. And we can encourage people to now go read the actual papers. And
I think it really deserves a reading.
Yeah, me too. So thank you again. Congratulations, Giancarlo, for a wonderful issue.
Thank you, Alex.
Mm-hmm.
Thank you for your, thank you for doing for this conversation, but thank you for your paper, because that was beautiful. That was powerful. That was strong. That was courageous. So I think it's a must read.
Thank you.